I'm Megan Ritchie. I'm a palliative care specialist based at Concord Recreation Hospital in Sydney, Australia. I would like to start today by acknowledging the traditional custodians of the various lands from which our attendees join us today, and to pay our respects to those elders past and present. I'm currently on Maramarang country, which is on the south coast of New South Wales. Please be aware that this seminar is being recorded, so we request that you keep your microphones on mute during the presentation. If you have any questions during the presentation, please type them into the chat and we will respond to these at the end. So today is the Facing Fatigue seminar series. Cancer Symptom Trials recently completed a Delphi study in adult cancer symptom research priorities in Australia and Aotearoa, New Zealand. Both consumers and healthcare professionals reported that fatigue was the symptom that was the most troublesome. Drawing on the Delphi study finding and given its relationship to other cancer symptoms, as well as its universal presence, we believe that fatigue should be a high priority for further clinical research. We are delighted today and thank Professor Fiona Cramp, who is joining from Bristol in the UK, where it is 7 o'clock in the morning. Professor Fiona Cramp is a physiotherapist and fellow of the Chartered Society of Physiotherapy in the United Kingdom. The focus of her research is facilitation of physical activity for people with long-term conditions. She is Director of the Centre for Health and Clinical Research at the University of West England-Bristol, which includes a wide range of research themes from musculoskeletal, neurology and pain to emergency, and cross-cutting themes of knowledge mobilisation with children, young people and families. She is an experienced doctoral supervisor and contributes to undergraduate and postgraduate teaching for a range of health professional programs. Fiona's seminar topic today is physical activity for treating cancer-related fatigue. Thank you so much, Fiona, for joining us and for doing the seminar today.
Well, hello, everyone. I would say good morning, but it's good afternoon for you and good morning for me. So what I'd like to talk about today is the role of physical activity in the management of cancer-related fatigue. And just to give an overview. So my presentation, what I'd like to do is just give a general overview of cancer-related fatigue and consider the management guidelines, just to provide the background context for physical activity. I also want to talk just very briefly about give a summary of the non-pharmacological treatments that have some evidence in the management of cancer-related fatigue before focusing down on physical activity, and then considering some of the strategies for promoting physical activity alongside the research that we have available to us. So just to set the scene then, when we're talking about cancer-related fatigue, we tend to use the National Comprehensive Clinical Network definition. And this is based on guidelines which are updated every couple of years. I should acknowledge that these are American guidelines, but there are also quite well accepted Canadian and European guidelines. So the definition is that cancer-related fatigue is distressing, persistent, subjective sense of physical, emotional and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. And there are a few key things that we need to note within this definition. The first of which is that cancer fatigue is multidimensional. So it's not just a physical thing, it can also affect people emotionally and cognitively. And we need to keep that in mind when we're trying to manage the symptom. The other thing to note is that the mechanisms for cancer-related fatigue are not really, they're not pinned down yet. There's a lot of suggestions have been put forward, but nothing has been proven. And there's a lot of variation between different groups of cancer patients, but also even within the same groups of cancer patients. So it's not easy to predict the course of fatigue. When we're trying to manage fatigue for individuals, we should think of this as the goals of fatigue management as reducing the severity of fatigue, lessening the distress that patients experience from fatigue, but also thinking about how we can decrease how fatigue interferes with daily activities. The key thing here is that we can't always reduce the severity of fatigue. So it's sometimes what we need to do is we need to be able to just help people to cope with the fatigue that they are experiencing, rather than thinking that we can actually have a magic bullet to get rid of it. We also know that fatigue is not well managed clinically, and I'm pretty sure that's across the globe, that we're not really addressing fatigue as well as we could be. It's quite often undiagnosed, undetected, and considered by patients and sometimes by health professionals as just something that you have to put up with as a part of the condition. So there are a few things that we can do, fairly basic things that we can do before we think about specific non-pharmacological interventions. So the first thing is it's really important that we screen our patients regularly, that we do this both during active treatment, but also post-treatment, because fatigue can persist for quite some time after any cancer treatment has finished. We should also think about educating patients about cancer-related fatigue so that they have some expectation of the fact that it might even occur, maybe just some tools in their back pocket as to how they can cope on a daily basis with fatigue. We also need to bear in mind that in advanced cancer, things can potentially be quite different, and the management might need to be different for fatigue in people with advanced cancer or those nearing end of life. Particularly their priorities may be different. They may be more reliant on carers, so it could be important to involve families and carers in that management. And whilst we're talking about physical activity today, and I will touch on this again later, it may not be appropriate to start trying to implement interventions like physical activity. So we really need to think about what the patient's priorities are. And for advanced cancer, things like conserving energy may actually be more appropriate, but I'll come back to that later. So where we do find that people have fatigue, there's a few things that we really should be doing initially. And this is before we think about specific interventions. So there are a number of factors that could be contributing to that fatigue experience, which we can potentially change. So for example, some patients will have high levels of severe anemia, and that would be the first port of call, is to try and reduce that anemia so that they have more energy with that respect. It may also be important to look at what medication they're taking, and that could be both medication for their cancer, but also things that they might be taking over-the-counter medications, any complementary therapies, just to see what they're taking, to see is it potentially contributing to their fatigue experience, maybe thinking about changing the doses of some of the medication to help them better manage their fatigue. And then other things to ask patients about are things like pain, any anxiety, depression, sleep problems, and also the nutritional status. So obviously there's interventions that we can do for each of those factors, possibly considering things like referral to a dietitian if they need nutritional support, and all those factors can influence their fatigue experience. If we've addressed all those things and fatigue is still present or it's still at a high level, then we want to think about moving towards our pharmacological and non-pharmacological management options. So in terms of pharmacy, there are a number of groups of drugs that have been investigated for the management of cancer-related fatigue. And without going into these in too much detail, I would just say that there's no strong evidence of large effect sizes for any of the drugs. There is some evidence that erythropoietin may be helpful for people who have high levels of anemia, but anemia really is only related to fatigue in approximately 8% of cases. So it's rather a small number of patients that will be affected in this way. The strongest evidence for any pharmacological medication is for methylphenidate, but even with that, the effect sizes are quite small, and the original or the primary data shows quite mixed findings. So not all the studies are showing that it's beneficial, but the overall effect size does give a small effect. It can be used for short-term use with those who are receiving active cancer treatment, and it can be considered with advanced disease. But one thing to note is it shouldn't be used for long periods of time. So 8 weeks is about the maximum that it should be used for. And if it's not proving beneficial within the first 24 to 48 hours, then it should be discontinued. There is also some evidence of dexamethasone, so psychostimulant, that it can have benefit in advanced cancer. But I think one thing we should note is because cancer-related fatigue is multifactorial, it's likely that any medication is only going to target one aspect of that fatigue. So the medication may not work for all people, and that's probably one reason why the effect sizes that we see are relatively small. So moving swiftly on then to the non-pharmacological interventions, there's a few interventions that have been shown to be beneficial both during cancer treatment and post-cancer treatment. And these are physical activity, which I'm going to come on to in more detail, psychosocial interventions, and CBT for insomnia. So CBT as a component of those psychosocial interventions, which is specifically for fatigue, and CBT for insomnia have been shown to have small effect sizes. During treatment, there are a few other, or during the cancer treatment, there are a few other interventions that have also been shown to have a benefit. So these are massage therapy, nutrition therapy, and bright white light therapy. And then post-cancer treatment, there are also a few others. So yoga does seem to have some benefit. Psychoeducation, which includes energy conservation and activity management. Mindfulness-based stress reduction. So there's a thought here that if we can reduce stress, anxiety, and depression in patients, that will help them to manage their fatigue. And finally, supportive expressive therapies. For supportive expressive therapies, expressive writing is the main therapy that has been shown to have benefit, but there are potentially others that could be considered, such as music therapies, art therapies. The evidence really for these interventions is based on adults. There's very little evidence in young people, so those below 18, and there's also very little evidence in those with advanced cancer. And as I said previously, the recommendations for people with advanced cancer, there's no real evidence-based recommendations. There has been shown to be a small benefit for physical activity, but we just need to be mindful that physical activity may not be acceptable for people who are experiencing advanced cancer or those at end of life. So it's really important to consider what their priorities are, and maybe consider that if physical activity isn't appropriate, that maybe energy conservation and activity management for important activities, so that they can do the activities that are important to them, may be a more relevant approach. So drilling down then more into physical activity, we're thinking really of physical activity having the strongest evidence to reduce cancer-related fatigue, or to help people to cope with cancer-related fatigue. We find in the literature that exercise and physical activity is often used interchangeably, but just to clarify, what we're talking about here is physical activity as any bodily movement that's produced by skeletal muscles that requires energy expenditure. So it's including everything, so leisure time, transport, and also any activity that you do as part of your work. Exercise is a physical activity, but it's a subset of physical activity. So it's more planned, structured, repetitive, and it aims to improve or maintain physical fitness. So there's a specific goal that you are trying to achieve with exercise. So it's just worth bearing that in mind when we're considering the evidence as to what we're referring to. So just thinking generally then about physical activity, there are, across the board, there's been quite a lot of systematic reviews in this area with meta-analyses, and the majority of them are showing that physical activity has small to medium effect sizes on cancer-related fatigue. So the evidence is there to support it, but the effects are not massive. Okay, we're not going to eradicate fatigue with interventions of physical activity or exercise. It is beneficial both during and post-cancer treatment. When we look at the evidence, the effect sizes do seem to be a little bit bigger after treatment, but we also know that if we can reduce fatigue during treatment, that it tends to be lower after treatment. So there's an argument that we should be looking at physical activity from an early point during the treatment pathway. The evidence is growing, and whilst 10 years ago we would have said that the majority of the evidence was only there to support exercise or physical activity in breast and prostate groups, we're now seeing other groups of cancer patients where there is enough evidence to support physical activity. That said, the mechanisms by which physical activity modifies fatigue are not yet clear. There are lots of proposed mechanisms. Just for example, we know that physical activity can reduce inflammation, and inflammation has potentially got a role in production of fatigue. We also know that if people are more active and they're fitter and stronger, that they find it easier to do tasks and perhaps get less physically fatigued. We also know that physical activity helps with reducing anxiety and depression. So there are lots of mechanisms by which physical activity can potentially reduce fatigue, but the exact mechanism by which it works for each individual is not really possible to predict at this stage. So there's lots of guidelines that suggest that we can use physical activity to reduce fatigue in cancer, but how we actually do that is less clear from those guidelines, and there are none of the guidelines that actually state how to do it. So we know from the standardized physical activity guidelines for the general population, so for the whole population we're looking at 150 minutes of moderate physical activity per week. So that's what's recommended for your normal everyday person, and to some extent that might be the target for people with a long-term condition, regardless of what that long-term condition is. But there isn't any actual evidence to suggest what's optimal for people who are receiving cancer or who have a cancer, or who have a cancer diagnosis or who are receiving treatment for cancer, let alone somebody who's got a high level of fatigue alongside that cancer and that cancer treatment. So we can't just go in with all patients and say, right, we're going to get you all up to 150 minutes of moderate activity per week, because that obviously wouldn't be realistic. So the other thing is about how we actually implement any interventions. There's a less evidence there on what we need to do to get people more active that would benefit their fatigue. So we know that we need more research in this area. In terms of what evidence there is, we know that all types of activity have a benefit for fatigue. The research suggests possibly that aerobic exercise or aerobic exercise with resistance training has larger effect sizes than resistance training alone. So that's one thing to consider, that whilst some patients would prefer to do resistance training and maybe find it easier to stick with that on a longer term basis, the actual benefits are better if we do incorporate some aerobic exercise as well. So that could be walking, swimming, running if people are able to. There is also some low-level evidence that higher intensity exercise is more beneficial. However, I say low-level evidence because the majority of that evidence is only in observational studies. So there's nothing that has investigated the actual causal relationship between exercise intensity and cancer-related fatigue. And we do know that even low levels of physical activity can be beneficial to cancer-related fatigue. So again, we just need to think about that on an individual basis. So there are quite a few challenges that we need to consider in terms of implementing physical activity. And we know that only about half of patients who are offered a physical activity intervention or an exercise intervention will actually undertake it, and even less will complete it. There are barriers to physical activity with everyone, the whole population. You know, you do a survey on the whole population, you will identify barriers to physical activity. But there are specifically barriers that we need to think about in relation to people with cancer and fatigue as well. So within a cancer population, the things that are stopping people from doing physical activity are the practicalities. So, you know, the time that it might take to travel to the venue, if they're not doing it at home, and particularly if they're supervised interventions, which again I'll come back to in a minute. People just aren't interested in doing physical activity, particularly if they don't have a history of being physically active. We tend to find that those who have always been physically active will continue to be physically active if possible with cancer, but those who aren't routinely or habitually physically active, it'll be more difficult to engage them. Embarrassment is a big thing. People, particularly, you know, if they've had bodily changes as a result of their cancer treatment, they may be embarrassed to be seen out doing exercise. Symptoms. So symptoms is a big thing. You know, we're talking about physical activity to reduce fatigue, but actually fatigue in itself can be a massive barrier to people doing physical activity. And also pain and depression can also be barriers. There's also quite often an erroneous belief with patients, but also sometimes with health professionals, that actually doing activity is going to make those symptoms worse. Nutritional status can also be a barrier in terms of people, if they have very poor nutrition, they won't have the energy to actually do the physical activity, particularly if they're dehydrated, etc. as well. Mobility can also be a problem, and then the medical status. And I think we should also just keep in mind that COVID had a further impact on people's ability to engage with physical activity behaviours, and a lot of that was to do with the reduced social support structures that were available to them. And I don't think we have, certainly in the UK, we haven't recovered from COVID in getting people back to their normal or previous levels of physical activity. So what can we do to address these challenges? Well, the first thing is we need to make it clear to people, both patients and also health professionals, what the overall benefits of physical activity are. So not just selling physical activity as something that can help their fatigue, but making sure that we tap into what's important to patients. So, for example, if people are having problems with sleep, you know, we can educate them on the benefits of physical activity for insomnia, and similarly with depression, anxiety, and pain. So it's not just about maybe helping them with their fatigue. We can also educate them onto the more general benefits of physical activity for their cancer, or for the symptoms that they're experiencing as a result of their cancer. We also know that if we use a trusted health professional with a tailored physical activity intervention, that people are more likely to start it and stick to it. And that trusted health professional's advice is really key whenever we ask patients about, you know, what is it you would want to help you do physical activity or be more active. Trusted health professionals comes up again and again. We might want to consider some behaviour change techniques to support the exercise uptake and maintenance. So, for example, things like motivational interviewing. We can also consider goal setting as important to participation. The research evidence also indicates that supervised programs potentially have better fatigue outcomes compared to those that are unsupervised. This is particularly the case in the short term, but we also need to think about the practicalities of that. Obviously, devising or delivering a supervised program is going to cost more. It potentially means patients have to be available at the time of the supervision, which may again not be practical. So we might consider some sort of adaptations to this. So for example, we could use web delivery, so delivery of interventions over the internet, and that could be in real time. or it doesn't always have to be in real time. There is some evidence in breast cancer patients that has been successful delivery, but we're thinking about having to be just adaptable to what resources we've got, and also the patient's needs. But what is key is that we ensure that people have access to whatever facilities or interventions are going to be suitable and acceptable to them. So in terms of additional recommendations, we also we know that walking programs tend to have better adherence than other types of physical activity interventions. And this is particularly the case when we allow people to self-monitor, because this provides them with a motivation. So for example, giving them real-time daily step counts using a pedometer. And then more recently, so in the last sort of 10 years, we've had smartphones and wearables which can also be used to help motivate behavior change. And obviously quite often people will have their own devices that they can be encouraged to use. But we just need to be mindful here of the health inequalities that can arise by some patients having access to this technology and others not having that. In terms of where do we start? So it really is important to individualize the starting point. I mentioned previously that, you know, national guidelines, we're trying to get everyone up to 150 minutes of moderate activity a week, or 30 minutes on most days of the week. But we need to be realistic. So for some people, particularly if you're suffering from high levels of fatigue, actually just starting with a reduction of sedentary behavior is going to be where you need to be. And really, you know, it's selling it to patients that all physical activity is better than rest. Okay, so, you know, getting up and walking around the house is going to be better than sitting on the settee. It's as simple as starting at that point. We want to be in a position where we're promoting energy pacing. So we want to avoid getting into the boom and bust cycles where people maybe go crazy for an hour, do as much as they can, and then spend the next 23 hours sitting down because they're exhausted. So we talk about this as sort of flattening the curve. So it's a keeping going at a low level of activity and gradually increasing that, rather than going all out and then collapsing in a heap. That said, there may be a case in advanced cancer that we need to think about what people want to prioritize. So if it's a case of they want to see their family for an hour and have lunch with them, or just spend time with them, then it may be that they use up all their energy in that hour, and we just have to accept that is doing the key thing that is important for them. So encouraging them, or you know, talking to them about how they can conserve their energy so that they're able to do those things that are important to them. In terms of just going back to the boom and bust and flattening the curve, it may be useful to use, certainly at the outset, it may be useful to use physical activity diaries and fatigue diaries so people can see what their patterns of behavior are. They can be really useful to then help with sort of counseling the patient and talking to the patient about what has their activity cycle been and how has it influenced their fatigue, and how can that be improved over time. So if you're detecting that there is a boom and bust cycle, getting them to reflect on that and think about how they can improve or flatten that curve moving forward, and gradually potentially increasing their physical activity levels, but without exacerbating that fatigue that's tipping them over the edge. So I think this really sort of leads us to the importance of individualizing physical activity and not assuming that one size fits all. So we need to think about a range of different factors, and these are just really the high level factors. So, you know, the person's age, their gender, their fitness level, the type of cancer they've got, how it's affecting them, and the stage of treatment that they're at. We often acknowledge that if people are receiving treatment, that they may need to actually just drop down their level of activity rather than trying to keep going at a higher level. In terms of implementing a physical activity intervention, We want to think about the frequency, so how often we want them to do a physical activity, the intensity, so how hard you want them to work. And whilst you can use devices to monitor the intensity, it quite often is better for patients to really just think about it themselves. So maybe using something like the Borg intensity scale, which is just how short of breath you are or how much effort you perceive that you are putting into the activity. The duration or the time of the activity, and also then the type of activity. So here we're thinking about whether it's like an aerobic or a strength training, resistance training, or even balance type activity. It's really important to identify short and long-term goals, but to do this with the patient so that they have ownership of the activity and also that it's an acceptable activity to them. You know, there's no point telling somebody to go and swim if they hate swimming. So we need to think about really individualizing those activities. We've mentioned about the national guidelines, and because we don't have optimal parameters for reducing fatigue in cancer, we are working towards that 30 minutes of moderate intensity physical activity on most days of the week. So don't ignore that target, but don't set out with that target as your initial goal with participants, and it may not ever be appropriate for everyone, but that's sort of something just to keep at the back of your mind. It is really important to progress slowly, and you know, you will also need to use probably health behavior change techniques to allow people to disengage from physical activity, to help them to re-engage with physical activity at different points on their cancer journey, but also to modify that physical activity as they progress through treatment and potentially through a cancer either spreading or coming back, and just reflecting on where they are at that point in their journey. And again, with advanced cancer, just to note that physical activity might not be acceptable, and we need to think about that as what's the burden on that individual of trying to get them to do a physical activity program. How interested and how motivated are they to participate, even when they know what the benefits are. So is it safe? Well, there is a lot of evidence to suggest that exercise programs and physical activity are safe both during and post-cancer treatment, but there are a few cautions that we need to just bear in mind. So for people with bone metastases, we may want to be careful with sort of weight-bearing exercise. With thrombocytopenia, so where they've got low in platelets and their immunity would be low, we may need to think about a lower level of activity, but also where they exercise. So going to the gym, going to swimming pools isn't going to be suitable for those individuals. If they're anemic, potentially treat the anemia first, but in the absence of that, don't overexert people. And then obviously being cautious where people have fever or active infection, or other comorbidities that they may have, either due to their cancer or other conditions. And that again is where it's really important to think about that individualization of physical activity so that we avoid any adverse events, exacerbating symptoms, risking infection, falls, fractures, lymphedema. So where have we got to in terms of the evidence? Well, there are quite a lot of limitations still in the research evidence. So whilst we do know that physical activity is beneficial, there are areas where the evidence could be improved. So the quality of the research evidence, we have a lot of the research to date has not used intention to treat analysis, so basically people are dropping out of trials, but we are just taking away their data, which doesn't really give us an idea of the clinical effectiveness of those interventions. Also in trials historically, there's been quite poor blinding of both participants, outcome assessors, and recruitment is quite often done on a voluntary basis. So the people who are coming to the trials are those who are interested in physical activity, which obviously gives us a skewed vision of how beneficial physical activity might be. That said, the quality of the literature is definitely improving. The trials have definitely improved in quality, so we are seeing stronger evidence coming through now. One of the key things that we need to think about, though, is whether the studies that are being undertaken are actually recruiting people specifically to reduce fatigue. So are they fatigued at baseline? Are they fatigued when they come into the trial? The danger, if they're not fatigued, then we've not got the potential for seeing a larger effect size. So a lot of the historical studies have just recruited anyone with cancer, and fatigue has often been a secondary outcome. So the actual benefit that we're seeing is fairly minimal because they may not have been fatigued at baseline. You can't improve something that doesn't exist. The other thing is the lack of long-term follow-up data. So we're seeing a lot of studies that have maybe put in a 12-week exercise program, and they've maybe only followed them up then for either to the point of 12 weeks where the intervention stops, or maybe only a month or so later. So we're not seeing much data on the long-term effects of physical activity in relation to fatigue. There's also been a really wide variety of exercise interventions that have been looked at, which makes it difficult to compare across studies. And there's a lack of direct comparisons of different exercise types. So, for example, there's very few trials that have done a head-to-head comparison of aerobic exercise and resistance exercise. There are a couple out there, but not very many. Also, the outcome measures that have been used quite often in the older studies, they tended to use a very generic outcome. So something like SF36, which for those of you who are familiar with that is a very generic tool which uses vitality as a measure of fatigue, which there's quite a lot of criticism of. And there's a lack of consensus amongst researchers as to which are the best outcome measures to use for fatigue. There's also limited evidence for young people, so those below 18, and also for an older population, for those over 60. And probably at this point should also note that the majority of the research is done on Caucasian populations. We need a lot more research done on larger demographic. And there's very little research with advanced cancer and end-of-life care. And again, whilst there is emerging evidence for a range of different cancers, the majority has been undertaken in those with breast cancer. And whilst some people may assume that it can be easy to transfer those data, I think, you know, we just need to bear in mind that different types of cancer or cancer affecting different parts of the body can have massively different effects. Just to give one example, so for example, if you've got a brain tumor that's affecting your sleep centers and you've got dreadful insomnia, then that's obviously going to affect your levels of fatigue very differently to something like breast cancer. So given that the limitations of the research, we also need to acknowledge that there are challenges to doing the research. So there is high attrition, so we get a lot of people dropping out from studies, and that can not just be for personal reasons. It could be, you know, due to the influence of their cancer. They may not just be able to continue participation. We also need to bear in mind that cancer-related fatigue is a really complex phenomenon. So I mentioned at the beginning that it's got multiple variables. You've got to think about the biological, the physical, and the psychosocial. So it's really hard to target something like that with a single intervention and expect it to be a magic bullet. We're also doing research in the presence of a background condition. So the cancer is potentially changing, it's maybe progressing, the treatments may be changing. So there's a lot of variables to consider. There's also quite poor uptake of physical activity, both in trials and also clinically, and quite often the perception from patients, but also from health professionals, that it's just part of the condition that you have to put up with. So we really need to get over that hurdle to change that attitude. It would help if we had a better understanding of the etiology of fatigue. That would be a really good starting point. And just to finish then with what I think are sort of some key recommendations. So in terms of clinically, where fatigue does persist, we need to consider that there is potential for physical activity programs, but they should be individualised to the patient's needs and preferences. Whilst the effect sizes are likely to be small, we may want to consider combining physical activity with other interventions. So we could potentially combine physical activity with cognitive behavioural therapy or other types of psychosocial interventions to really maximise the benefit, and also think about whether physical activity or maybe a psychosocial intervention would be appropriate for some patients rather than others. And this would really help to reflect the multidimensional nature of fatigue. In terms of research, we really need to acknowledge that cancer-related fatigue is a complex symptom, but also that physical activity is a complex intervention. And based on that, the traditional randomized trials or randomized controlled trials are potentially only providing us with part of the picture of the benefits that physical activity can provide. And in my view, future research that investigates physical activity parameters really needs to drill down into what works for whom, for which types of patients it works for, and how we can better tailor those interventions to individuals. So really looking at sort of what works for whom, in what circumstances, and based on that, I think we need to look at, in addition to the randomized controlled trials, we need to take more of a realist evaluation approach to our research in the future. And I'm just going to finish because I just want to make you all jealous of where I live. So this is where I am in Bristol. This is the campus that I work on at the University of the West of England, and this is the view out of my back door. And I shall open to any questions that you might have.
Thank you so much, Professor Cramp. That was a fantastic presentation. And what an amazing workplace you have. I think we all feel a bit jealous about that. I'm going to go, first of all, to a question from Vanessa Jensen. Vanessa asks, "Hi Fiona, do you have any survivorship programs for exercise or physical activity in the United Kingdom? I'm 24 years in remission and experience post-cancer fatigue, but also fatigue to getting older and having had COVID, and to get into exercise, build muscle, increase fitness. But then once I get sick, everything goes back to below my baseline, and it's a big effort to just get back to the start. I'm aware that I am so far out of the usual monitoring recommendations aren't relevant or timely, and I only go to the late effects clinics once a year. Just wondering how this is addressed in the United Kingdom or specific to where you are, given that people are living longer after cancer."
Really great question. It's patchy. So the way that our health service works I didn't want to touch too much on health services because it was obviously very different, the context in the UK as it is to Australia and many other countries. So within the UK, whilst we have NHS evidence, which provides recommendations across the board, the actual commissioning of the services is done on a regional basis. So it is very patchy as to what's available for people. In the region that I'm in, we do actually have two quite good services. So we do have late effects clinics, which sounds similar to what you're experiencing, and that has to be accessed via referral. But we also have a physical activity intervention, which is delivered in local leisure centres, which is specific to patients who have received treatment for cancer, so who have finished their cancer treatment. And that is really popular. Now, it's not specifically targeting fatigue, but it is basically any health professional can refer to the service, and the patients can then access that supervised supported gym session once a week. And I've spent some time in that service. It's delivered by a sports rehabilitation specialist, so they are qualified to support people with cancer. I think that's level 4. We call it level 4 reps. And the problem with that is there's a massive waiting list for people to get in there. So they can only accept, I think they only run it twice a week. So there's 2 groups attend twice a week in the local leisure centre, and there is, as I say, there's a massive waiting list because it is so popular. The popularity of it is not just the physical activity, but that camaraderie, that group support that is provided through that service, and for people to be able to talk about their experiences. Unfortunately, I don't think that's available across the country.
Thanks very much. The next question I have is from Victoria Turner. I haven't heard of bright white light therapy. Can you please tell us more?
Yeah, so it's not something that I personally have used, but basically it's the same concept as people who have like light therapy in the mornings to help with depression. So it's it's simulating the sunshine, simulating the light that you would get from going outdoors and getting a walk in the sunshine. So obviously, depending on where you live, you may not, in the UK, always get access to much sunshine. It can be quite cloudy sometimes. So it's just giving people that regular dose of bright light therapy. It's supposed to improve vitamin D levels, and it also helps with sleep cycles. So the body's melatonin adjusts because you're getting that bright light therapy in the morning. Then when it comes to downtime at night, you get a better night's sleep. And that's the theory of then how it reduces fatigue levels.
Thank you. Next question is from Paola Valli. Can sitting exercises improve physical activity? And are there any basic ones that can be recommended?
Wow, good question. I think, just going back to what I said, any physical activity is better than simply sitting. So as a starting point, or if you do have reduced mobility, then I would suggest that yes, sitting exercises are definitely better than doing nothing. I don't think there's any research evidence on the benefits of sitting exercises. I could be wrong, but certainly not for fatigue. There's no evidence, or there's no research undertaken. So it doesn't say it doesn't work, but there's just no research that looks specifically at sitting exercises for fatigue. There is more generic research that's been done, particularly with neurological patients, actually, to show the benefits of sitting exercises. I think anything that you can do that helps with keeping mobile. So I would suggest trying to find a class that does sitting exercises if possible. There's loads of internet options. If that is not possible, you can access internet. So really, upper limb exercises, mobility exercises, but also there are exercises that you can do in sitting that actually will improve aerobic capacity. So you're thinking of things like arm cycling, if you can get access to arm pedals, where you're actually physically, increasing your heart rate, increasing your breathing will definitely be beneficial.
Thank you. We have another question from Swad. We're interested to hear antidepressant medications and the influence on fatigue for patients with cancer. For instance, the direct impact on energy levels or the change in mood, increasing interest and engagement in activities versus fatigue.
Yes, so pharmacological management is I would say not my area of expertise, but there is some evidence of small effects for antidepressant medication. My personal view, and I would say this is my personal view because I don't think I can speak from an evidence-based perspective at this point, but if you are experiencing severe levels of depression in combination with fatigue, then I would suggest that the antidepressant medication could potentially have quite a good effect to reduce both the depression but also the fatigue. I think, as I said in my talk, the drugs that are used only have one mechanism of action. So to use them for all fatigue would probably be the wrong thing to do. So I think in some patients they may be beneficial, but I don't think you can assume that they would be beneficial in all patients. And I think we just need to be mindful as well of the potential side effects that might occur from taking, drugs, particularly if they're being taken unnecessarily. My preference would be to try going down a non-pharmacological intervention approach initially, unless there is a really good indication that those drugs could be helpful. So as I say, potentially in the presence of high levels of depression or severe depression.
Thank you. I think you've spoken so well about, the beast of the multimodal cancer-related fatigue, and hence why trying to do randomized control trials is so difficult in outcome measures. I do have a question regarding outcome measures. You mentioned that there is debate on the best outcome measure to use. What is your preferred screening for cancer-related fatigue, and also your preferred outcome measure in looking at cancer-related fatigue?
Oh, that's a difficult one, because I think historically I always liked the multidimensional fatigue symptom inventory, the short form, for actually measuring fatigue in clinical trials. And the reason for that was because of the multidimensional nature of that tool. I think whatever you do use, it's really important to have the multidimensional concepts within there, so that you're actually able to differentiate between physical, emotional, and cognitive fatigue. That said, I think more and more we are now moving towards the EORTC QLQ C30. And again, it's multidimensional. I think whatever we use, it just needs to be something that's consistent for most research trials. If we can at least try and find something that is acceptable to all researchers and to patients, that would be good. In terms of screening, I think I would tend to keep it really simple. And I don't think there's anything similar in cancer, but we've developed a screening tool for rheumatology patients, which I think could be very easily adapted to cancer. And it's basically a set of 3 numerical rating scales. And it's to do with basically how much fatigue has affected you over the past week in terms of its severity. And it's a 1 to 10 scale. And then it's how well are you able to cope with your fatigue? And again, a 1 to 10 scale. So it's a really simple thing that patients can fill in really quickly, but it will give you that breakdown of, are they experiencing a high level of fatigue, but they are able to cope with it, or are they experiencing sort of moderate levels of fatigue, but actually they're really not coping well with it. It's affecting their daily lives quite severely. And I think in both those situations, we would need to consider interventions. So I think, for screening, I would keep it really simple. And I would quite like to see those adapted screening tools for cancer, that we're all using the same terminology and the same tool to actually screen.
Thank you. We do have one last question from Maddie, but I'm aware that it's actually time. So maybe, Fiona, if you're happy to stay on the line with Maddie after, we'll see how we go.
No problem.
We'll let other people go. So thank you so much, Fiona, and thank you everyone for attending. That was a really informative and great seminar series. Fiona, would you like to share your webpage for research so we can continue to follow you?
Yeah.
For all attendees, the next Facing Fatigue seminar is in November. So the details are available on the website there, along with how to register. So please stay posted. Thank you so much, Fiona. I hope that the rest of your day is wonderful.
Thank you. It's a pleasure.
Sharing your time this morning. Really appreciate it.
No problem at all.